All right, another Thursday. You know what that means. We don't have too many tickets on the docket today, so why don't we just get started? First one, it's essentially rehashing something we talked about a couple of weeks ago. This one is just another study that's yet showing a relationship between the lumbar multifidus muscle morphometry, pain, and how much fatty infiltration is in there. They also tried to standardize it and rule in and out avoidance beliefs, insomnia, and spinal degeneration in this one, but the result is essentially the same, similar. While seeing fatty infiltration, the fatty infiltration itself is not the progenitor or cause of somebody's low back pain. They are highly, highly correlated and overlapping. Ergo, if somebody has chronic low back pain and has a lot of avoidance beliefs, they're not using their back and they're letting the muscle atrophy and letting fat come in, they're more likely to have higher disability and more pain or more pervasive chronic low back pain. So this one is just another overlapping study about what we've talked about before. So let's spend a little bit more time on the next two studies. So first up, comparative safety and efficacy of manual therapy for cervicogenic headaches. So we have a subspecialty of headaches, cervicogenic, or headaches that stem from or believed to be stemming from the neck. These are very commonly thought to be similar or the same as tension headaches when it's not technically actually the same. They just happen to be in the same area with similar structures involved. And what they did was they wanted to compare the safety and efficacy of things like spinal manipulation, mobilization. So basically what is traditionally thought of to be a chiropractic specialty, which arguably it is. We're the profession that spends probably the most time learning it and most time applying it, but it is not exclusive to our profession. So spinal manipulation, that high, quick, it's technically called HVLA, high velocity, low amplitude, that quick in and out, speedy maneuver. A mobilization, which we can grade as well based upon how much force and speed is put into the mobilization as well. Think of it this way. If it's a 5-point scale, 5 is a manipulation and adjustment. Mobilization is every gear up to that point. And massage for the management of that specific headache subtype. Basically, they did searches, Cochrane reviews, PubMeds, a lot of different ways to come up with their information. And what they found, or what they distilled down to, was 14 studies that had almost 1,300 patients, these with cervicogenic headache patients. They did a meta-analysis where they revealed that something called a SNAG, a sustained natural apophyseal glide mobilization, which is something that we do here in the office, as well as teach our patients how to do a version of it at home, because we were trained that it did exactly what the study is showing. It had a huge improvement compared to non-SNAG interventions for cervicogenic headache. So basically, if we teach patients how to mobilize their neck in a very, I don't want to say very deliberate, but in a very informed way, we can get them to reduce a lot of the pain that stems from these types of headaches. Now, I want to cover some other things in this study because it's rather interesting. So the SNAGs, the sustained natural apophyseal glides, maintain benefits over time. That's why we teach it to patients with this subtype of headache. Is it's easy to do. It has a lot of benefit. Essentially, the ROI, return on investment, time you need to do it versus how much you get out of it, is huge, along with the fact that it's very, very safe. Now, they also showed in a network meta-analysis that visual analog scale pain, so basically the chart that you see at a medical doctor's office with 0 to 10 or frowny face to smiley face, this meta-analysis showed pain improvement. And they basically talk about, they rank it on a curve, but here's the fun part. Cervical spine manipulation had the best short-term incidence for pain intervention with this type of headache, followed by mobilization, followed by exercise, then massage. And for disability indices, neck disability indices, same thing or very similar results. Cervical spine manipulation had the best or most significant effect in the short term, followed by mobilization and then exercise. But then massage also had a pretty good jump in efficacy here, which Cool. I love massages. But let's talk about this. And I like the way that they go about this, especially down here in the conclusion, but let's work our way there. Cervical spine manipulation exhibited significantly greater visual analog scale reductions compared to exercise, massage, and mobilization, while mobilization was superior to exercise and massage for that same pain scale. For neck disability, basically a patient asking how well can they use their neck in certain situations and activities of daily living, this cervical spine manipulation was significantly better than exercise, but no other between group differences were observed. So you may be thinking, aha, I don't have to work out. No, 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 no. Let's go to the conclusion, then I'll give you my thoughts. So what they say is with patients with cervicogenic headaches, so remember, a specific type of headache, snag mobilizations can significantly improve pain and function with benefits maintained in the long term. Additionally, cervical spine manipulation may be the most effective short-term intervention for reducing pain and disability compared to the others studied. But clinician expertise appears to be an important factor, and they need to add this sentence on, as well as patient preference and patient preference after a proper informed consent, because there are certain classes of patients that I will lean more towards one over the other. A lot of it comes down to patient comfort with the procedure, because let's be honest, not everybody likes the thought of having a practitioner do an adjustment on the neck. And I'm not going to force it upon them, because even if in this one study, cervical adjusting had the best outcomes compared to others, that didn't mean the others didn't have clinical outcomes from the get-go. Basically, comparing adjustments to mobilizations, sure, adjustments edged out mobilizations, but mobilizations still had significant impact in both the short term and long term. And I can teach somebody how to do a snag. Suffice it to say, if you're comfortable with it, you're informed, and you have a cervicogenic headache, I'd be more than happy to adjust your neck, especially if we find something worth adjusting. If you're not comfortable with it, we'll go right into a mobilization and teach you how to do a snag. You're still going to get an exercise though, because, well, oh, it doesn't, just give me the snag, give me this. Like, yeah, that's great for the headache, but I also want to reinforce, buttress, and give your neck something to do, because, and I have to state now, this is from this point on more of an opinion, but a lot of what precludes people to developing cervicogenic headaches typically stems from, at least in today's society, too much sustained inactivity. So if I give you different movement snacks or ways to go about your day-to-day job with those exercises where we can keep the joints talking and communicating and essentially full of nutrients, because a lot of these joint structures work through diffusion to get their nutrients, not just, oh yeah, blood goes here and it gives everybody nutrients. Not for a lot of these structures. It requires active movement to have these things diffuse through a membrane to get to these what are called avascular structures to provide nutrients for. So if I can give somebody something that may not have a pain effect, like, okay, the exercise isn't going to be comparatively improving your pain nearly as much as these other things, it's still going to have such significant impact on the condition as a whole that you're getting it regardless. So in conclusion, for cervicogenic headaches, one more time to emphasize, cervicogenic headaches, adjustments are great in the short term, snags are fantastic, and we can teach patients how to do it. Mobilizations are still a worthwhile consideration, especially if you are a patient population that cannot, should not, or are not comfortable with adjustments. And we still have things like massage that can help with patients' disability questionnaires when it comes to this condition. So I like this study. It covers a lot of things that we can do in the office, as well as a lot of what other practitioners that we refer and collaborate with can do. So I really, really like this study, and I hope you learned something from this one. Now, this one, what to talk about when it comes to this one? Modic changes, at least as far as this title is concerned, modic changes are associated with increased pain intensity, greater disability, and a reduced quality of life in low back pain, a cross-sectional study. So first, we have to talk about what a modic change is. And for this one, I could talk about it, but I do have a patient handout. Let me make sure you guys see my screen. Yeah, okay, you still see it. So modic changes and modic classifications are essentially something that is going to be viewed on an MRI. And what happens on an MRI is we have T1 versus T2 weighted models, and there are other things that you can get really fancy with MRIs, but let's just keep it simple. We have T1s and T2s, and they essentially will highlight different structures depending upon its weight, how the image is weighted. What do I mean? Well, in one of them, fatty material is going to be much brighter. And on the other, we're going to have more watery material become brighter. And what happens is a lot of times you'll compare the two to see if that bright, shiny spot on the MRI, is it more, is it a harder substance? Is it a fatty substance? Or is it a more watery substance? And that will help classify what you're looking at. And we can see that between type 1 and type 2 changes. So let's start with the type 2. So with modic type 2 changes, fat replaces some of the bony edema or swelling that's happening within the bone for whatever reason, whether it's trauma, degeneration, etc. But you're starting to get additional fat accumulation within the bone here, typically around the end plate. And you'll see that on one of the MRIs. It'll pop bright white because fat will be highlighted in that MRI image versus it will be dull in the comparative MRI study. So it'll be bright on the one that highlights fat. It'll be darker on the one that highlights just more of a watery substance. Versus a modic type 1, you'll have the opposite because this one is more, arguably it's more acute stage, even though you see these in chronic patients. You see that bony edema or how do I think of it, like bone swelling. Like your bones aren't actually swelling, but it's the same process. You have inflammatory markers invading the space to try and deal with a problem at the site. So think of it as bony inflammation or swelling, and I'm using quotes very deliberately here. So this is bony edema or inflammation within the end plate itself. And so they try and color that here. And you'll see that brighter on, I believe it's the type 1, no, type 2. Yeah, H2. Yeah, T2s, I believe, are brighter with the watery substances. T1s are brighter with the fat. So when you compare the studies, if the one that highlights water is brighter than the fat one, modic type 1. If you're dealing with one that highlights the fat more than the watery one, you're dealing with the type 2. Now, there is a type 3 where there's actual bone remodeling within the end plates. But I want you to understand that concept when we're talking about these modic changes and their relationship to pain. I mean, I could go into a whole other TED talk about bones, a living material, even though we always associate it with the dead. It's constantly remodeling. It's where you get your most of your blood actually produced from, is within the actual marrow of a lot of the bone. So it's a living, breathing material that's constantly remodeling. And these changes are just a classification series, especially when you see it on an MRI, about what is going on within the bone. Is it going through a process, an active change? Is it something we need to be concerned about? Is it associated with age, associated with trauma, associated with pathology? All of those are individual discussions with the patient at the time when we see these. But let's go back to the study now that we have at least, hopefully, a not too confusing overview of what modic classifications are, so that when you see it and hear the word, you now have a visualization of what's going on. Now, let's reread the title. Modic changes are associated with increased pain intensity, disability, and reduced quality of life in low back pain, a cross-sectional study. So they wanted to see if modic change parameters, including their type, extent, if it's associated with low back pain. And they compared intermittent low back pain to chronic back pain. So basically back pain episodes to just chronic sustained low back pain. Are these parameters associated with participant-reported duration and intensity of low back pain? And are those modic parameters associated with worsened disability and poor quality of life? So let's just, I'm not really going to talk too much about the study other than they really pared down what they wanted to, or who they wanted to study. So they basically said almost 20% of the things that they were looking at were excluded because of lack of results in clinical examination. So 18% of the participants in the study were excluded because of that reason. Another quarter of them were excluded because of pain in other locations. So they wanted to be very specific, like this is just low back pain, which I can respect and appreciate. So of the starting 1,218 participants that they were looking at, 58% met the quality criteria that they were looking for. So 712 patients or participants in the study. The mean age was 42 plus or minus 11 years, and it was slightly more women than men. And they basically tried to not standardize, but collect demographics to really understand what was going on here. Let's see here. They blinded evaluators so that you had people just blind reading the MRI reports, so they didn't have an idea of like, oh yeah, that's Jim. Ah, that makes sense. Nope. The people reading the MRI reports were completely blind. They just graded them on a modic scale, as well as how much area they saw that actual bony change from the end plate happening. So where is it here? Yep, 3 evaluators blinded to the participants' demographic information, health status, assessed the modic change parameters. And what did they find in the results? Among the modic changes that we talked about, so modic type 1, modic type 2, as well as total area that they saw, so how much of the bone from the end plate was affected, when type 1 modic changes were observed, they found higher odds of chronic low back pain and intermittent low back pain after they ruled out or adjusted for potential confounders. When greater depth and area of modic changes were observed, so essentially bigger change or more change happening within the bone, they found higher odds of chronic low back pain, but not intermittent low back pain. In the chronic low back pain group, they found that the type 1 modic changes were associated with a slightly higher maximum pain intensity, and multiple modic changes were associated with modestly longer duration of chronic low back pain. Increased modic depth, so more into the bone away from the end plate, was associated with slightly higher pain intensity in the chronic low back pain group, but not the intermittent. Now, type 2 and single modic changes were associated with slightly worsened pain-related disability. The presence of modic changes was also associated with slightly poorer quality of life, particularly in terms of physical health. So let's finish with the conclusion. I'll kind of give my thoughts on this. I don't have that many that are going to dispute what's in the actual study. I'm just going to try and make sense of it from hopefully a patient perspective here. So in conclusion, based on these results, they came to the conclusion that these modic changes were found to be associated with higher odds of low back pain, greater pain intensity, and worsened pain-related disability and quality of life. Type 1 and larger modic changes were associated with slightly higher pain intensity of chronic low back pain and reduced physical function. I love this bit. Our study associated modic changes with these findings, but it was not designed to demonstrate a causal relationship. Future studies will need to do that. Modic changes in health conditions, as well as whether targeting modic changes could offer a potential approach to alleviating low back pain, need to be in future studies. So, what's going on? Again, it's similar to the multifidus thing. It's the association and correlation. We don't have a causation. Basically, if I was to, all right, let's talk about a causal relationship. Here's a knife. Now, granted, this is on social media, whatever. I'm in Wisconsin. If this knife was to slip and cut me, we would have an injury that I can say that caused my pain. It was obvious. You cannot dispute that cut when you see it happen caused that. However, if you see somebody with a cut, you cannot just say, aha, I know a knife did that. No, we don't know that. It could be so many other things that actually caused that person to have a cut. And if I see somebody with a recent cut, I don't know if that person is actively going through pain because I all of a sudden look on myself. It's like, oh, shoot, I got a cut back there. When did I get that? Just because we see these things does not automatically mean there is pain and that we can automatically distill it down to a single source, right? Hopefully you're with me with that explanation. Now, at the same time, we also know if somebody's juggling 6 knives and they have a couple of cuts, we can make some assumptions. So that's what I'm saying happens clinically, is while we can't say that these modic changes are causing the back pain, we know that they are there. And because somebody's going through a physical process where the bone is changing, it does make sense that they are likely to experience worse pain, especially depending on the type of modic change. So like with that modic type 1, where we have that arguably fresher edema, that fresher swelling, something is happening where the bone is starting to change. I can easily make sense of it where, okay, so yeah, somebody would have worse pain with that compared to somebody who's not going through a modic change because the bone is restructuring itself. So I can make sense of that correlation. I am not saying that that modic change is causing them pain. I am saying that they are going through something that is causing that modic change to happen, and whatever is causing that modic change to happen can also lead to pain. It doesn't seem like much of a difference, but it is huge. And I'm sorry if it's confusing and if I sound repetitive. I really want to just get that point across. It's similar to other conditions. There are conditions where the pathology itself, yes, is pretty causative for pain, or the treatment intervention is causative of pain. Like it just, yes, it causes pain. But there are others where it is just a correlation, right? And that's what this is saying. These are associated, they are highly correlated, they are overlapping, and there seems to be, if your body goes through, or if the bones and the end plates need to go through an active change to accommodate what is happening in your body. So put another way, if your body is developing modic changes because it's going through some sort of a stressor, lesion, or pathology, that it needs to have those modic changes happen. It needs to have inflammation around the end plates to try and heal, adapt, etc. It makes sense that they're going to have a worse quality of life, worse pain, etc. because of whatever is leading to that state of being, that final domino that is tipping the scales for the person to develop these modic changes. So this study makes sense, but we do not get the right to jump to the conclusion that seeing a modic change, like if I see an MRI and I see a modic change on there, it's like, aha, that person must be in pain. We don't get to do that. Okay. I see it. That person is going through a modic change. Something in their life is causing them, something in their body is causing them to go through a modic change. I have to factor that in. They have a higher odds of having worse pain, worse activity, or worse quality of life that I have to bring them back from, but it is not a guarantee, and I cannot just say, yeah, that's a crappy MRI, it's going to be a crappy person, or a crappy spine, or a crap. No, it is a factor in care. It is a sign that may indicate how much work and what type of work needs doing. And like this study says, maybe we can do a study that will show a more causal relationship, and maybe then we can use it as a parameter for healing, because then if we have a causal relationship and if we're able to reverse or reduce, therefore we can pull back pain. So we may be able to use it as a marker in the future. We cannot now. We just get to look at it and say, all right, for playing poker, this person has a higher odds because these are so associated of having a worse quality of life and worse pain. So I like what the study is saying. It can be confusing, probably mainly just from my explanation of it, but I hope we understand that when we look at this and we see these things on MRI, your spine, your bones, your end plates are going through a process of change. We have to understand that, maybe make sense of it. Like it could be a factor as far as the research right now, as far as why you're feeling as bad as you are. And we need to pull you back and rehab you or treat you or diagnose whatever we need to do with you to help you through this. Okay, that's where we're at now. In the future, if there's a cause, then maybe we can use that MRI in the future. Like, hey, look, there's less area, there's less edema. You're acting, like there should be less pain, but that's not right now. So 3 studies. I can still ramble on. I probably made things from crystal clear to clear as mud. So I'm going to probably stop right here so that I don't confuse anybody any further. And if you have any questions about this, if I had first started like, oh yeah, that makes sense, to what the heck is he talking about, reach out to me. I'd love to clarify it. Leave a comment either on my social page where I post this or my YouTube page. I just love to make sure that these things are as clear as they can be while still inputting a level of nuance and discussion into it, so it's not as black and white and sensational as social media makes it out to be. Because the harder it seems that we talk on social media about everybody knows the one cure, the one thing, the one, the more confusing it actually gets and nobody knows what's happening. I still deal with patients that don't know nutrition, don't know pain, because it's on both ends of the spectrum. There's, you should always have pain when you're doing this. You should never have pain when you're doing this. You should never eat this, always eat that. It's a mess, and I'm just here to try and give my own spin on things so that patients understand where my perspective is to help them through the absolute mess that is out there. So, and last call to action. If you want any comments, if you want anything that's clear, because I didn't do that great of a job and made things clear as mud, DM me, comments. I'm just here to give you the information. Till next week.